everyone. Thank you so much for coming. I'm Mary McLean. I am one of the APDs at St. John's Riverside Hospital in Yonkers, New York.
Hi, everyone. I'm Linnell Campbell. I am a PGY4 at Jacobi in the Montefiore programs in the Bronx.
I'm Miriam Kulkarni. I'm the program director at St. John's Riverside Hospital. And today we're going to talk to you guys about implicit bias, how it affects your learners, and what you can do about it. So we're going to start with a thought exercise. I want you all to close your eyes and really try to imagine the students I'm going to talk about in your mind. Try and form a mental picture of them. So the first two students I want you to imagine are a married couple who are trying to match into EM and neurosurgery. They're excited, but they're nervous about matching into two competitive specialties. Picture them in your mind. The next student I want you to imagine is the highest achieving medical student in the third year class. This person is an academic and research superstar. Picture this student. Okay, now imagine a student who is clearly a leader among their peers. Someone who is president of their class, who has leadership positions in multiple organizations, the kind of student who you just know is going to wind up being chief resident wherever they match. Now imagine a student who comes to medicine as a second career after an extremely successful career in business, culminating in a stint as the CEO of a Fortune 500 company. And the last student we want you to imagine is a third year student who came to medicine after winning an Olympic gold medal. When you were imagining these students, were the couples matching students a homosexual or a heterosexual couple? What was the race of the two high achieving students? What was the gender of the former CEO? If you're like many people, the couple that you imagined was heterosexual. The two high achieving students you imagined were white and male. The former CEO was also white and male. These underlying assumptions are natural and part of being human. They're also examples of implicit bias, which helps contribute to the unequal learning environment faced by our students and residents. It's very clear that bias affects how we care for our patients. There's a large body of work that shows that health outcomes are worse for patients of color, for obese patients, and for patients from many marginalized populations. But how do these biases affect our learners? In talking about bias, as many of you know, there's two different types of bias. Explicit bias is overtly discriminatory words or actions. This is still happening in our hospitals and medical schools, and it's clearly wrong and it's clearly unacceptable. Implicit bias is different. Implicit bias comes from our subconscious mind, and it's a side effect of how we process information. Implicit bias stems from unconscious associations that affect our behavior and sometimes even run counter to our conscious thoughts. Both of these are affecting our learners. In a study of female residents in multiple subspecialties, 93% of them reported discrimination based on their gender. The interesting thing, though, is that the most common sources of those discrimination were the patients, the nursing staff, and the patient's visitors. In looking at the kinds of discrimination that these residents experienced, it was both implicit and explicit. So they experienced feeling that they had less trust from their patients and from co-providers. They were asked to do non-medical tasks. They felt like they were given less responsibility, but they also were the recipients of gender-specific explicit verbal exchanges. Multiple studies have shown that students and physicians of color experience overt and implicit discrimination at all levels of training. These experiences range from misidentifying their roles, not thinking of them as the medical student or the doctor and assigning another role instead, to explicit derogatory comments, to being expected to serve as race ambassadors. In a study of 227 IM residents, it was shown that residents experience a lot of bias from their patients, and that physicians of color, and especially female physicians, have more experience more bias from their patients than physicians who are white and male. It's also been shown that transgender and non-binary students and physicians experience discrimination. So in a study of 21 students and 15 physicians who identified as transgender or non-binary, half of the participants and 60% of the physicians hid their transgender identity from their medical school or their residency. They reported barriers on the basis of gender identity and expression when applying to medical school and residency. More than 3/4 of the participants in the study censored their speech or mannerisms to avoid unintentional disclosure of their transgender or non-binary status. More than 2/3 of them reported hearing derogatory comments about transgender or non-binary individuals at their medical school, their residency, or their practice. In a study that used focus groups with LGBTQ students in 4 Michigan medical schools, they found that medical students reported a hard time managing their sexual minority status, and that students felt that their sexual minority status made it harder for them to relate to faculty members and for them to find faculty mentors.
So in the short time frame of this didactic, it will be impossible to give a complete list of all the different types of implicit bias that can affect your learners. But we do want to mention another type that's getting more and more attention nowadays, and that is weight bias or obesity bias. And fortunately, Dr. Kulkarni, Dr. Campbell, and myself have been on a research team investigating interphysician weight bias, and our manuscript is on early release in Academic Emergency Medicine as of the end of April of this year. So essentially, with our cross-sectional observational study, we sought to determine the patterns of interphysician implicit and explicit weight bias in the medical workplace. We hypothesized that the majority of physicians do possess interphysician implicit weight bias, and that the degree of implicit bias has a direct relationship with explicit weight bias. So essentially views and practices. We used the Project Implicit Association Test, or IAT, principles, and we created our own implicit association test to measure interphysician weight bias. We created and used silhouette images of obese and average weight physicians, and we chose previously historically used words that describe good and bad physicians. This IAT was administered alongside an explicit bias scale of questions adapted from a previously validated scale, as well as another scale, which was a novel creation by our co-investigators called the Professional Weight Bias Scale. We essentially, with that third scale, we were attempting to gear the questions more toward daily practices seen in the medical workplace, like seeking advice from consultants. Overall, 620 physicians and medical students participated. Descriptive analyses revealed that 87% of participants had some degree of implicit interphysician anti-obesity bias, with 31 and 34% of those physicians falling into the moderate or severe category, which was remarkable. Then we get into our correlation and multiple regression analyses, which did reveal that male sex, increased age, and decreased body mass index of the participant were related to increased implicit bias possessed by the participant. And this was after controlling for all other factors. Furthermore, Implicit, explicit, and professional biases all had significant direct relationships with each other. I try not to spend too much time on item level analyses, but we do have a few here that we want to mention. First of all, 17% of physicians agreed with the statement, "I really don't like fat physicians very much." 15% agreed with, "Fat physicians make me somewhat uncomfortable." And 14% agreed with, "If I were an employer looking to hire, I would avoid hiring a fat physician." And just a side note here, we used the word fat intentionally and with reason, because I do recognize that this is an insensitive word. We were very careful with word choice, and we stuck to the previously validated literature for these scales. Our findings highlight the prevalence of interphysician implicit weight bias, the strong correlations between implicit and explicit weight bias, and also the potential disparities faced by physicians with obesity. This kind of information can be used to guide implicit bias training for more inclusive medical workplaces. And it is so important that we're aware of this, because obesity does exist among physicians, and multiple prior publications have made sound arguments that people struggling with obesity are a marginalized group. If you'd like to read more in our early release version, you can follow this QR code. We're very excited about the work.
So the reality is that most patients, nurses, and even fellow physicians are expecting to see this guy when they hear the words, "The doctor will be in to see you in a minute." And these assumptions affect every interaction our learners have. Think about the impact it has on the clinical performance of a student or a resident when the patient or even another physician assumes that they're the nurse or a member of the cleaning staff. Think about a transgender student who listens to the medical staff make jokes at the expense of a transgender patient. Think about it, how it impacts performance if nurses see you as less trustworthy, not because of your qualifications, but because of your gender, your race, or your ethnicity. For students from marginalized populations, this doesn't just happen once or twice, it's a pervasive and persistent feature of their education. It's also important to realize that bias is built into our methods of evaluating students. In a recent study of MSPEs, white students were more likely to be described with standout words such as best, excellent, and outstanding compared to their non-white peers. Furthermore, female students were more likely than males to be described as caring and compassionate, and less likely to be described with words that don't denote intelligence and competence. Even the evaluations that we consider to be the most objective have an element of bias. Studies have consistently shown that Black, Hispanic, and Asian medical students on average have lower USMLE Step 1 scores than white students, and that women on average score lower than men.
So, implicit bias can lead to education, training, and career-long disparities for your learners. When we look at attending physicians, fellows, residents, medical students, pre-med students, all the way back to primary school, everyone's path has been affected by their own race, gender, and other factors. The challenges that they go through in their lives are never ending. Essentially, from before the time that they've even entered primary school until after they retire from their career, there will always be effects on such important aspects of their professional life as admissions to big programs, evaluations, testing, promotion, workplace interactions, salary, and the ability to achieve success in their field, particularly in academic medicine. These are only a few examples of things that they struggle with. There are numerous others, and we'll talk about these over the next few minutes. The so-called leaky pipeline has been referenced for Black men starting as early as elementary school. Underrepresented minorities are pushed away and deterred from pursuing medicine because of society's structural isms, because they make it so much more difficult to achieve success for them. Barr et al. Published this article back in 2008. The investigators had done a longitudinal survey of 362 underrepresented minority pre-medical students at Stanford University over the course of their undergraduate years. Underrepresented minority students and women showed a disproportionate decline in their level of interest in pre-medical studies over the course of their undergraduate years, with the final result that fewer actually applied to medical school in the end. And this was in contrast to those students who did not identify as underrepresented minority or female. So, we know that implicit bias is affecting your learners even before they get into medical school, and it also affects who even gets in the door at medical school. One perspective piece published in Academic Medicine just in the past few months discusses an achievement gap disparity in academics and standardized test performance that exists between white and underrepresented minority medical students, like Dr. Kulkarni was talking about. It notes, like I said, that the gap begins early in preschool, and it widens and becomes more disparate through the educational years and through medical education in particular. Underrepresented minority medical school students are more likely to fail courses, to graduate late, and to score lower on their STEP or COMLEX exams or their other licensing exams, even after controlling for their pre-medical science GPA and their MCAT scores. And this can limit their specialty choice, their competitiveness for residency, and many other career opportunities. And it has very long-lasting implications. Multiple articles have also found that learner exposure to discrimination during their medical education can have significant effects on their decisions regarding specialty choice and practice setting. And this kind of pattern is actually, it's quite concerning, partly because it may mean that certain specialties or certain practice settings where there tend to be more discrimination experienced on learner rotations will not end up getting these underrepresented minority or female learners matching into their specialty. And thus these specialties will become even more disconnected from these underrepresented groups and women in medicine. And yet another study published in 2016 showed that female physicians make on average almost $19,000 less than their male counterpart physicians after adjusting for work hours, productivity, and experience. So the gender pay gap does still exist in medicine. Like I said, there is still a pay gap adjusting for work hours, productivity, and experience, and only a third of the active physician workforce in the US is female. This graphic shows some of the main results from the AAMC 2018 through 2019 State of Women in Academic Medicine Exploring Pathways to Equity study. This analysis found that while overall the proportion of full-time women faculty at medical schools has been rising and is now actually over 40%, it is still disproportionate to the number of medical school applicants and graduates who are female. And also disproportionate is the number of underrepresented minority women on faculty at only 13%. And this has unfortunately risen by only 1% in the past decade. And a larger percentage of men than women are actually moving up the ladder in the shorter term. And while there has been a slow but steady increase in the number of women department chairs over the past 10 years, we still sit at only 18%. But does bias and discrimination actually lead to things like burnout and other things that we are very concerned about in our learners? Well, yes, they do. Nunez-Smith et al. Published an article in 2009 with results of a national cross-sectional survey of 529 physicians randomly identified by the AMA master file. They assessed relationships between racial ethnic discrimination in the medical workplace and outcomes such as physician turnover, career satisfaction, contemplation of career change, and other things. They had some very remarkable findings, and I'll outline them here. First, underrepresented minority physicians were significantly more likely to have left at least one job because of workplace discrimination. Second, physicians who experienced racial ethnic discrimination had a higher job turnover. And third, of those physicians who had experienced workplace discrimination, only 45% were satisfied with their careers versus the 88% who were satisfied who had not experienced this discrimination. And 40% were contemplating a career change altogether versus only 10% of those who had not experienced discrimination. So I'll kind of bring home the message here and distill it down. Underrepresented minority health professionals experience harmful bias and discrimination from colleagues, peers, and patients. And these professionals experience negative impacts, including career dissatisfaction, burnout, turnover, and attrition. The effects are also self-propagating when it comes to burnout. In this study of over 3,000 resident physicians, symptoms of burnout were actually associated with greater possession of explicit and implicit racial biases towards Black people. Furthermore, recovery from those symptoms of burnout were associated with reduction in that explicit bias. Prior work has revealed an association between bias and suboptimal care delivery for patients. So it is reasonable to deduce that because increased burnout is associated with increased bias, it can also be a factor in disparities in healthcare delivered by these individuals. There are significant implications for the quality of healthcare for underrepresented minority patients. There's also a minority tax on underrepresented faculty. This is an interesting and very well-written article that was also recently published in BMC Medical Education. They found that in addition to the already taxing challenges that non-underrepresented minority learners need to face during their medical education and training, underrepresented minority learners also find themselves up against additional challenges. And these include biased interactions with nurses, techs, fellow physicians, patients, and their family members and other key players in the emergency department and elsewhere in the medical workplace. They're also up against bias in testing, evaluations, and other standard measures of medical education performance. And a new topic here, they find themselves struggling to find mentors who know exactly what they're experiencing and who can help them navigate through these challenges specific to underrepresented minorities. This is a big one. Then there's COVID. So we would be doing ourselves a disservice by not mentioning what has happened in the past year and all of the changes that have come along with COVID. First, we're going to go through some of the CDC stats, and then we'll talk a little bit about how this can indirectly and directly affect your learners. So from the CDC are the rate ratios for underrepresented minorities relative to white non-Hispanic people. What I want to highlight here first are that the rate ratio of positive cases for Hispanic or Latino persons and American Indian, Alaskan Native non-Hispanic persons is quite a lot higher, disproportionately higher for both of these groups relative to white non-Hispanic persons. The hospitalization rate was also high for these groups and disproportionate to even with the case positivity rate. And the death rate was more than twice that of white people. And this trend is interesting for Black people when we look at it. The overall case positivity rate was actually not much higher than for white people, but the hospitalization and death rates were significantly and disproportionately high. Now you think about how your learners might be affected by this if they identify as being from an underrepresented minority group who are experiencing these worse outcomes. Even if they themselves are not experiencing it directly, if they have family members, friends, or even just the knowledge that their group is going through this, it has profound impacts. But why is it that we're seeing these poor outcomes for underrepresented minority groups? Well, there are some interesting trends that we can look at. For example, AKI is a common COVID complication, as you all know, with one study reporting a 37% rate of AKI development for hospitalized patients. There's a 35% death rate among those patients who did develop AKI in the hospital. And this is compared with 16% overall death rate in hospitalized patients who did not develop AKI. Well, AKI was more likely to be diagnosed in Black patients than white patients. Another example is multi-system inflammatory syndrome, MIS-C, which has disproportionately affected pediatric patients in racial and ethnic minority groups. Over 70% of reported MIS-C cases occurred in Hispanic and Black pediatric patients. But then there's this, and this is the point that I really want to get across with COVID. A study published about 6 months ago actually looked at levels of anti-Black implicit bias among white people in almost 1,000 counties across the United States. And they correlated this level of implicit bias, which was gleaned from implicit association tests, with COVID outcomes in those counties. And they found that high levels of implicit bias correlated with higher case positivity in both the Black and white populations, interestingly. And it also correlated with larger Black-white incidence rate gaps. Higher levels of anti-Black bias among white people also predicted worse COVID outcomes and greater inequities. So that is extremely interesting and disturbing.
So the reality is that it's not just that our minority learners were practicing in this environment where the outcomes from COVID and the rates of COVID were so unequal, and dealing with the psychological fallout from practicing in that kind of environment. It's also that providers who were minority providers were actually disproportionately getting sick. So this was a study that looked at users of a symptom reporting app. It was a large prospective study in both the UK and the US that had users that were healthcare providers and that were just community members. And what they found was not only that healthcare providers were more likely to get sick than people in the general community, they also found that minority providers were more likely to get sick than non-minority providers, and that minority providers were also more likely to report that they had inadequate access to PPE. So it's not just that our learners have been operating in an environment, where COVID showed inequities for patients. They also have been practicing in an environment where, the exposure to COVID and the rates of getting COVID and the provision of PPE was unequal for providers.
So now that we've talked about all of these issues with society today, we are going to pass the torch on to Dr. Campbell, who will recommend some tools for your toolkit to actually address implicit bias to improve the situation for your learners.
Okay, thank you. So what's an individual to do when bias is encountered? So experiencing bias can cause many intense emotions. Many factors determine our response to bias, such as the relationship with the person displaying the bias, the context of the encounter, how we perceive the situation will be handled, just to name a few. While there's no one way to counteract bias, since it is a multifactorial issue, we've created a framework to stratify how to approach dealing with bias by instituting levels of prevention. Primary prevention is the ideal approach. It helps us get away from the reactive approach that we see all too often. If your institution has not done these things or doesn't have these structures already in place, there's no better time than now to start preparing them. The first thing is who and how your institution recruits and hires needs to be examined in order to ensure that there's not only a diversity of experience on the team, but a diversity of ideas and backgrounds. We all have blind spots when it comes to bias, so it will be a best practice to ensure that we're each other's checks and balances when looking at existing structures, metrics, protocols, and policies, which is another part of this tier of prevention. Analyzing existing structures, such as those mentioned before with a diverse team, helps to retrospectively examine how, who, and why these were put in place, and creates a forum for discussion surrounding whether or not there are a pipeline to bias for learners, staff, and for patients. As some of you may already know, psychological safety is paramount in all of these discussions surrounding bias. The one way to achieve this is to implement an anonymous bias reporting system, which must simply be more than just ranking statements, but should have a narrative section. Of course, this is something that will need to be reviewed in a timely manner, and the data must be analyzed and discussed with the aforementioned diverse group to institute and to create a pathway for intervention and change. Finally, education. We can use existing structures within our educational activities to teach how to refrain from being biased and how to react to bias. For example, simulation activities can be used to train learners how to deal with bias when it's encountered or witnessed. There can also be faculty training sessions to learn how to have discussions with learners who encounter bias, and how to also have discussions with students or residents when they witness them being biased or being the victim of bias. We have to also ensure that we place the same urgency on sessions dedicated to implicit bias as we do other educational activities. Ideally, it should be integrated into the curriculum or professional development milestones. Unfortunately, primary prevention doesn't always work. In such cases, we have to move up to secondary prevention. Some of this may be a bit repetitive, but it definitely needs to be in this section as well. Again, having a timely response to anonymous reports is imperative, because each minute that passes by without identifying and starting processes to curb bias is another opportunity for the disease of bias to infiltrate. These reporting systems should be monitored and analyzed at minimum on a weekly basis. If bias is witnessed or encountered, it should be corrected as soon as possible in a respectful and educational approach. We have to always remember that we all have blind spots, and sometimes the words we use and ideas we communicate are not always intended to be malicious. So we have to extend the grace and the benefit of the doubt and the hope that nobody wants to negatively affect the mental health or performance of a colleague. However, when we do encounter blatant and unremorseful actions, we must have systems in place for escalation and reprimand. And once the review and analysis is done on the reporting system, techniques such as a root cause analysis can be used to identify patterns, policies, or culture that led to bias, so that action plans can be created for mitigation, either at the institutional or individual level. And just like with any other types of preventive methods, some situations do warrant tertiary methods. In the case of bias, it'll be in response to the most serious cases. Some examples of these tertiary responses include remediation plans, reporting to HR and the legal department. And this tier has to also include mental health resources. Paramount to all of this must be transparency as well. When applicable and permissible, there should be an open discussion about patterns of bias that are highlighted through the data collection, review, and analysis that were previously mentioned. While it can be shameful sometimes to bring this to light, the shame should be alleviated by a culture of working towards eliminating bias and supporting those who encounter it and creating structures for that support. So I hope this helps add to your toolkit a little bit more.
We're so glad that you all came and joined us today. We are just floored by the amount of discussions regarding bias that have been taking place at these national conferences. And it's the discussions that we need to be having. Thank you so much for joining us. We would be happy to answer any questions that you have, or if you'd like to have any discussions online at this point, then feel free to speak up and ask questions. Here's our list of references. There's a lot there.
Hello there. My name is Gil Salazar from UT Southwestern. Thank you for this amazing presentation. One of my biggest goals for this upcoming academic year is improve our recruitment of underrepresented minorities for emergency medicine residencies. And there's definitely kind of a dichotomy. Some programs do well, others don't. So I'm very curious to hear y'all's thoughts about kind of implicit bias in the interview process for applicants and how we might mitigate that risk. And thanks again.
Absolutely. Thank you so much for attending and for that's an awesome question. I think it's multifactorial. I definitely think it's important to kind of understand that some of the metrics that we use to evaluate applicants, like the USMLE, that it's not a complete picture and that there's a level of bias there. I mean, it's really hard, right? Because you also want to recruit residents to your program who are going to pass your boards, and we don't have a ton of great predictors of that. Definitely, there has been some evidence that USMLE, like, if you get, it's not a fantastic predictor when the scores are really high, but when the scores get below a certain level, then you have to be concerned. So definitely that's an aspect to kind of broaden your perspective and broaden your metrics. And even when you look like at someone's extracurriculars, just keep in mind that, someone might have done less because they were trying to work and trying, or they had family that they were trying to support. So definitely, I think being holistic in your application review is helpful. I think having a diverse faculty is extremely helpful. I know we have an entirely female program leadership, and we get a lot of, when we interview female applicants, that definitely resonates with a lot of them. We get a lot of comments about that. So definitely, I think having voices at the table who are diverse helps to kind of foster that in your program. And I think it also depends on the resources that your program has. I mean, there definitely are programs that have scholarships for underrepresented minority applicants to kind of help them defray the cost of doing an away rotation. I think that's a fantastic way to recruit. But I also am aware that not every program has those resources. We don't have that resource. We're not able to do it. So I think sometimes it's hard if you're smaller and maybe less well-funded to kind of still have a seat at the table in terms of recruitment.
Yeah, I just wanted to add to that. I think that's a great question, Dr. Salazar. And I think it's a question that many programs have. One, we already know that there's a smaller pool to pick from, but then we notice that they go to specific programs. But I think it's also sometimes how applicants feel on the interview day that makes a huge difference. Because I can tell you just from personal experience, sometimes you have the sort of dilemma of, okay, I'm at this program, there isn't much diversity. They say that they're committed to diversity, but do I choose to be quote unquote the token, or do I go to a place where I'm more represented? There's a great article, and I can't share it in the chat for some reason, but if it's on the New England Journal of Medicine, if you just Google or type in interviewing while Black, it was a great article that was put out from Harvard about some of the, I guess, situations that Black applicants feel while already on the interview. So I think sometimes it's not a matter of, finding qualified applicants. I think that was always, the concern before then. They do interview at places. It's just, when they go there, do they feel as if they're patronized? I've had, medical students come to me and, they're like, oh, the first question the interviewer asked me was, hey, like if a patient called you the N-word, how would you feel? And that's a very, I mean, these, yes, I just, I mean, these are things that some people may think, oh, I'm going to ask this person this question to make them feel like, we care, but it actually has the opposite effect. It's also about students feeling that they have an advocate there, right? It's good enough to say, it's not good enough to say that, oh, we have a diversity and inclusion program, but when they talk to other residents at the program, they're like, oh, well, I'm not interested in that. I'm not part of that club, to sort of make it seem that it's this club that only, certain people are interested in, rather than it being a culture of the program. So I think that's a very important part to really focus on. Again, then there's the imposter syndrome and, really finding out what your applicants are looking for, in terms of interest. Not every minority or underrepresented applicant is interviewed in diversity and inclusion, but oftentimes that is oh, well, we have diversity this, we have diversity that. Some of them, don't care about that. They want to focus on ultrasound. They want to focus on critical care. And so they feel a lot of times that, again, even though it's well-intentioned, kind of what I mentioned, that it's actually has the opposite effect. So I think that's a great article to just take a look at. I mean, they have a very nice table of some things to just check off. And I think when you're having your planning committees for this upcoming interview season, these are things to really look at. And it goes back to what I said before about looking at policies and looking at the way that, you've always done things, and focusing on, wait, like, wow, I didn't know that was wrong. Maybe we have to try a different approach this time to make people feel more inclusive and to feel that they're not there as the Black applicant, that they're there as an applicant who just happens to be Black.
I think that, one of the things that we may struggle with in actual interviews is coming up with appropriate questions that that don't give the wrong message, but that actually can start up a conversation. And there was a webinar put on by Emra, I believe, that actually Linnell was one of the people that put this webinar on, and I have a whole ton of quotes from her in my notes page right here, and I was just about to quote our own speaker Linnell. But another thing that was said in this webinar is that transitioning from more unstructured interview question sets to an actual set of pre-thought out structured interview questions that have been known to be good conversation starters is another really, really good idea. So that's something that I've put a lot of thought into for this upcoming interview season.
Thank you all very much.
Thank you very much for your amazing presentation. I am Yvette Calderon, and I work at Mount Sinai Beth Israel. I was wondering if you guys could comment on what your thoughts are about how to be more proactive within the residency, recognizing that that in an urban city, emergency department, you are going to have these biases, and perhaps you have faculty that have these biases. So how, if you can comment on what you do, because we, as you've mentioned, these biases, stereotyping, affect the way they do on their, standardized exam. Not because they don't know their medicine, but because of all of the external influences. And so I'm just wondering how you guys deal with that.
Thank you so much. That's an awesome question. I think a piece of it is definitely being proactive. And, I think that's what struck me when I was when we were putting this presentation together, is that, a lot of the sources of bias are things that, a program or a department, you don't have any control over, right? You have very limited control over what your patients say and do, for example. But it definitely means that, resident students, they have a ton of interaction with patients, and their interactions with patients absolutely affect their education and they affect their work environment. So, I think one piece that we try to do in our program that I think is really important to do is you're proactive, right? You acknowledge that bias exists in patients. You try to give students and residents things that they can have in their toolkit when they encounter it. And you also educate the faculty, right? And you make sure that the faculty has a response. If a patient says something that's just awful to one of your learners, or if they don't want to interact with your learner because of some, because of their gender or their race, that you kind of make sure that your faculty are prepared and ready to respond to those situations, because they will come up. And I think a lot of times what happens is there isn't a discussion about it. So no one really knows how to handle it. So the responses are very variable. And a lot of times your learner doesn't know who to turn to, especially when it's someone who they know that you have limited control over, like a patient or even the nursing staff. I think it's different when they know as a faculty member, because most of them know that faculty members get evaluated and that faculty members have certain expectations in terms of their behavior. If I have to, choose what kind of bias is easiest to deal with, it's easiest when it's, someone who you as the program director have a little bit of control over. But I definitely think that there are There are ways that you can prepare your learners to deal with it. I definitely have things that I have in my toolkit that I say when I encounter bias in my patients, and all of my learners know about those things because I've shared it with them. And likewise, I have the expectation, and I've educated my faculty, and they know that when our learners come to them and they say that they've had this kind of bias, this patient say something to them or this nurse say something to them, they know that it's not something they should ignore. They have some things in their toolkit for how to address it.
Right. Thank you so much for that question again, Dr. Calderon. I know your name very well in the Jacobi community.
That was my home for 23 years as an attending. Miriam knows that too.
Yes. So I think just, the mere fact that you realize it, like Dr. Kulkarni said, that you need to be proactive is definitely a start. But I also take it as sort of one of the things that we have to do when we are trying to sort of be better at this is what I call like auditing the culture. Sort of where do we stand right now? Do residents feel comfortable enough to one report? Do they feel comfortable enough to do it laterally? Like if they see a colleague who is encountering bias, do they feel comfortable enough? Do they even know what to say? Do they know how to handle it? And if they don't know how to handle it, do they know who to go to? So I think that's one thing that's one way to start, by auditing the culture. And I think there's also a part about empowerment. I think a lot of times people don't stand up or they don't report because they don't feel like, oh, well, whatever I say is, no one's going to take me seriously. Everyone's going to think I'm just being sensitive or I'm having a bad day as a resident, which happens. So I think it's empowering people to feel comfortable enough and to feel powerful enough that they do have the opportunity to make a change and to call it out and to give sort of education about it. And I think, and I look at it almost as being like a mandated reporter, how we are for children. Like you have to be a mandated bias reporter. That's everyone's charge. You have to be, because if you're not, you're just silent, you're just going to continue to perpetuate it. And then we don't move anywhere with this. And then also, like I think I mentioned before, that we shouldn't be ashamed to say that we're not doing well, or that, hey, I was in attending and I saw this happen and I really didn't do anything for the student. I didn't say anything. I didn't know what to say. I didn't even know if I should say anything. I didn't know who to go to. And I think we have to sort of create a culture, and like I said, that psychological safety to make people feel like, and I always like to say, like, it's okay. Like, it's okay. We're all new at this. Nobody's perfect at this. These are very sensitive issues. These are sometimes very subjective issues for certain people, especially people who tend to be on the other side of the spectrum, who are not, the quickest changers in our culture of medicine. But I think that's a very open discussion that needs to be had, and it needs to be a protected discussion, or in the certain spaces, so that people are like, look, like, this is why this is important. This is why saying something like that is not right, or why not saying anything is detrimental, and this is how it can be detrimental. Because at the end of the day, you want your patients to be cared for well, and you want to make sure that your residents and everyone on your team is performing at their peak performance, right? And I think that's, and sometimes that's how I frame it. It's not about, or it is about feelings, but when you think about the bigger picture, some people just don't perform well after experiencing something like that. You have residents that won't go up for leadership positions. You have residents that won't participate in research, that won't, reach out when they're struggling because they don't feel empowered. So I think that's a very big part of it as well. And also, like I said, other than that, just be deliberate about it. Have like a phrase that you can give residents, that you can give faculty to use. Like, this is bias. What you're doing right now is bias. Or, did you just encounter bias? How do you feel? And sort of have this, 3 questions maybe that you can come up with, that in a situation like that, these are 3 questions that you can ask.
I really appreciate all your comments, Dr. Campbell. I actually agree with all of it. And I love how you phrased it. It is imperative that everyone in the community speaks up. It can't be just a set of people. It has to be everyone. So thank you very much. You guys did an incredible job.
Thank you.
Thank you so much. I think we're actually out of time. I put my email in the chat. So if any of you guys want to reach out after the talk is over, if you have any additional questions, thank you guys so much for coming and for your fantastic questions.
Yeah, what a great discussion. This has been awesome. Thank you.
Thank you, everyone.